Hi, my name is Brian Carey, VP of Marketing here at Unbound Medicine. Welcome to today's webinar, where Dr. Paul Kim will discuss evidence-based rationale for the use of esketamine in treating depression and suicidal ideation, equipping healthcare professionals with foundational support for its consideration in patient care. Dr. Kim is an assistant professor of psychiatry and behavioral sciences at the Johns Hopkins University School of Medicine. He is currently serving as the medical director of the Johns Hopkins Esketamine Clinic. Dr. Kim is a key contributor to the Johns Hopkins Psychiatry Guide, which is published and distributed by Unbound Medicine. Please use the QR code on your screen to start a free trial. Dr. Kim will be answering questions live following the presentation. To ask a question, please type in the chat or in the QA box at any time. I'll turn it over to you, Dr. Kim.
Thanks, Brian. All right, so today I'll be talking about ketamine and esketamine and the treatment of depression and suicidal ideation or behavior. I guess the goal of this talk is really to give everyone in the audience a general overview of these drugs and sort of the science behind it and our clinical experience with esketamine here at Hopkins, and maybe just at the end touch on maybe potential future directions and considerations, and open it up for questions. And I don't have any financial disclosure or conflict of interest related to this talk. And again, the outline, I'll discuss the background and the science of ketamine and esketamine, and then go on to talk about the clinical trials and the real world outcomes, which is our experience with the medications and future directions and considerations. So even though esketamine was recently approved for its treatment for treatment-resistant depression and major depressive disorder with suicidal ideation and behavior, this the idea of targeting an NMDA receptor or the glutamate hypothesis has been around for over a century. So ketamine inhibits this excitatory NMDA glutamate receptor. And in 1959, D-cycloserine, which is an antibiotic to treat tuberculosis, was shown to have an antidepressive effect, and binds to this D-serine site of the NMDA receptor. And so I guess the initial idea, the thought that glutamate signaling may be involved has been around for a while, but around similar time, the serotonin hypothesis really took off, and then which ultimately led to development of SSRIs like Prozac and Zoloft came onto the market. But in the around, I would say, 1990s, this idea, the glutamate hypothesis, was revisited and started to gain some support. And one of the early animal work showing, again, the effects of blocking the NMDA receptor and showing some antidepressive effect was using these two molecules, AP7 and MK801, where mice were given either control AP7 or MK801 and looked at the force swim. And so the idea is when mice are not depressed, there's less immobility. So with treating them with these NMDA receptor antagonists, at least there was a decrease in that immobility. in other words, they were more active in that type of setting. And same with MK801, while really there's no effect on the actual activity that they noticed in the open field, where mouse are allowed to roam freely. And around and in 2000, this was the early clinical study looking at the antidepressant effects of IV ketamine, where patients, this was a study, less than 10 patients were given either IV ketamine or placebo, and they saw a really dramatic effect of IV ketamine on their mood. So, even within 24 hours, they saw a pretty rapid improvement in the mood. And so again, not to get bogged down in too much detail, but so the overall like hypothesis is that there's this unbalance of glutamate and GABA, and also more decrease of glutamate and GABA neurotransmitters in the brain. GABA being the inhibitory neurotransmitter, and so under the non-stress conditions, there's a nice balance between the inhibitory GABA neurotransmitters and the excitatory glutamate neurotransmitters. And so, and because they had appropriate levels of these two neurotransmitters, there's nice integrity of the signal that is communicated between cells. However, under chronic stress or depression, or decrease in BDNF, which is a neurotrophic factor, or genetic vulnerability, or other factors, leads to decrease of GABA and glutamate. And so there's this low signal to noise ratio, and sort of impairing this signal integrity. But when you treat with ketamine, it reverses that. And so that's at least our current understanding of why molecules like ketamine and esketamine, by inhibiting the NMDA receptor, has this antidepressant effect. So just kind of taking a step back and looking at ketamine, the molecule itself. So ketamine is this molecule shown on this slide. And so there are really two forms. There's the S-ketamine, and then there's the R-ketamine. And so, just like your hands, they're pretty much identical. So just like our hands have, thumbs, finger, pinky finger and ring finger and so forth, but you can't overlap them, right? So they're mirror images of each other. And that's what S and the R ketamine are. They're mirror images of each other. And even though they're just mirror images, in biology, it has a significant impact on sort of efficacy sometimes. And, one form can be active and the other form may be inactive. In this case, it doesn't seem like there's a major difference, but because they both bind to the NMDA receptor and they both inhibit the NMDA receptor. And this inhibition leads to some dissociative effects and sometimes hallucinogenic effects. And in 1970s, IV ketamine was approved as a dissociative anesthetic, and they were very helpful for a lot of short surgical procedures, and it has a pretty short half-life. So, the effects, the sedative effects of ketamine would wear off relatively quicker. And so as I mentioned before, the real only difference between the S-ketamine is that it has greater affinity, greater binding to the NMDA receptor than the R-ketamine. and thus possibly having greater effect on that receptor. And so, I think the drug companies took the one that bound better to NMDA receptor and tested it. And in 2019, esketamine was approved for treatment-resistant depression, which treatment-resistant depression really means that somebody with major depressive disorder who have been tried on at least two oral typical antidepressant at a good therapeutic dose for a good duration. And so if they failed two of those trials, then they were considered treatment resistant. And about a year later, uh, it was also esketamine was also approved for just major depressive disorder with suicidal ideation and behavior. And again, just looking at a little bit more in detail the mechanism of ketamine and esketamine is that it binds to the NMDA receptor, and if in this GABA neuron, it prevents the release of GABA. Again, GABA is an inhibitory neurotransmitter, so it prevents the release of glutamate. So if you block the inhibitor of something that's releasing the glutamate, it will increase the release of glutamate, which will bind. We think primarily through the AMPA receptor, which is different from the NMDA receptor, to increase the release of this neurotrophic factor BDNF, which ultimately leads to synaptogenesis and has this antidepressant effect. And again, NMDA receptors are expressed in these glutamate, these excitatory neurons as well, and so the inhibition of that also increases the release of BDNF, because it is thought that the activation of NMDA receptor actually inhibits the release of BDNF. And just a couple of differences between the S and the R ketamine is its metabolism and the potential biologically active metabolite of S or the R ketamine. So with R ketamine, there's this compound, this metabolite. Well, one, it goes from ketamine to norketamine, and then from norketamine, it goes to hydroxynorketamine, and it's this compound right here. And this has been shown to actually activate AMPA receptor directly, again, so it could release the BDNF, but it also could inhibit this other receptor, which inhibits this glutamate release. So again, inhibiting the inhibitor leads to the activation of glutamate release. So this is metabotropic glutamate receptor that this hydroxynorketamine could bind to. And again, in mouse models, they have noticed some difference between the R and the esketamine. And in this model, the social defeat stress model, this is where an aggressive mouse would attack another mouse, and over time they become socially defeated, and they have these mouse behavioral phenotype that resemble some of the phenotypes that we would see in people with depression. So it has been in the past used as a model for depression or inducing depression. And so when you treat it with either control saline or R-ketamine or S-ketamine and do various behavioral studies, such as sucrose preference. So if if the mouse is socially defeated, then there's a less desire for these animals to want sugary drinks. So there's a decreased preference for sugar or sucrose. Whereas if you treat them with R or S ketamine, there's an increase of that. And so, maybe R ketamine has a bigger effect than the esketamine. Again, no difference in the actual locomotion of these animals. And again, as we talked about before, the immobility, so when they're sort of depressed, they tend not to move in certain incidences. So when you suspend animals by their tail, they move around a lot, but when they're socially defeated, then they don't do that. So there's an increase of immobility under this condition. But when you treat them with R and S, there's more movement. And, it seems like R ketamine may have a little bit better effect than the esketamine. And then this is a forced swim test, same idea, with vehicle or sailing condition. There's increased immobility after the social defeat stress. But with R and S, there's an improvement with maybe slightly better improvement with R ketamine. And and when you look in their brains, it also seems like there are more of these uh, uh, dendritic spines that are formed with RNS, and again, possibly more with the R ketamine than the S ketamine. So maybe there's some benefit, but at least in people, we don't really see the difference between maybe the R and the S, and as exemplified by this treatment with IV ketamine versus the intranasal ketamine. And so IV ketamine, again, has both the R and the S ketamine. And, when you treat patients with IV ketamine, there's an improvement of depressive symptoms. But with the intranasal, there's also an improvement. While it may seem like it's not statistically, there's maybe a slightly better improvement with the IV, but statistically, there's really no difference with the intranasal and the IV ketamine. Interestingly, in this study, when they actually looked at the lower dose of esketamine, it may have a better effect than the higher dose, suggesting that it's not necessarily giving a increasing the dose doesn't necessarily lead to a better outcome in terms of treatment. So that's sort of the general overview and background of ketamine and esketamine. Obviously we could talk longer about it, but I just wanted to highlight some of the important points about ketamine and esketamine, and also really distinguishing the difference between ketamine and esketamine, in that, when they talk about ketamine, they're really talking about the R and the S ketamine, like the racemic mixture of the two. And typically when people talk about ketamine, they're referring to the IV formulation. And with esketamine, they're talking about the intranasal. So, just focusing on the esketamine and the approval, so once there was a lot of data and evidence that ketamine and esketamine can help in the treatment of depression, there were bigger clinical studies done, and this was one of the studies that was conducted that ultimately led to the approval of esketamine for treating treatment-resistant depression. And as you can see in this trial, the esketamine, plus the antidepressant led to a significant improvement over the just antidepressant plus placebo treatment group. And also the other important thing is that when there's an improvement of depressive symptoms with esketamine, there's a difference between patients who are continued on the oral antidepressant versus the patients that were given placebo nasal spray and are also continued on oral antidepressant. in that their relapse rate is significantly greater in the placebo group. So there's more patients that showed relapse. In this graph, they looked at a patient without relapse. So there were more patients with the esketamine treatment without relapse compared to the placebo nasal spray. In this Transform 3 clinical trial, they primarily looked at elderly population, and fortunately, they didn't see that benefit in the elderly population between the placebo and esketamine. And here in our clinic, we've this is the old data, but again, we saw that there were improvements of treatment-resistant depression patients with esketamine. And although we didn't see a dramatic improvement, in the early days of the treatment, there you could see that over time, there is an improvement with esketamine, intranasal esketamine treatment. And again, I think one of the differences between maybe the clinical trial results and ours might be that we had patients whose current episode of depression was quite long, over 100 months of kind of dealing with depression, and also a number of antidepressants that they've tried and failed, which were again 7 antidepressants on average, the patients that we treat here at Hopkins. And something that's interesting is that it seems like possibly the change of blood pressure may indicate whether patients may respond or not. But again, this would require like a bigger study to really confirm that that effect. And we often get asked, whether from patients whether they should do either ECT or ketamine or esketamine. And this was a recent study done looking at exactly that, which is ECT versus the IV ketamine. And in this study, really, there's really no difference between the ECT and ketamine. So they all respond pretty well to either IV ketamine or ECT. And I guess the only major difference is that with ketamine, there's really not a significant effect on their memory or their cognition compared to ECT, where there's significant impairment of memory and cognitive function. And so finally, just briefly, just sort of discussing the future directions and considerations. So, I think we are currently looking for other potential NMDA receptor antagonists without sort of the sedative, dissociative effects. Now, it may not be the molecules that act directly on the NMDA receptor, but possibly downstream of the NMDA receptor. That would be very helpful so that, we could prescribe, as of now, with intranasal esketamine, they have to come into the clinic and be monitored for 2 hours. And because of these, side effects from esketamine, and with if you could have a drug that acts similarly but without these dissociative effects, then potentially you could just take them at home without coming to the clinic. And the other things really to see is trying to figure out which population will respond to oral antidepressant versus esketamine, or ECT versus esketamine, because then we could really, instead of having patients try a bunch of oral antidepressants and having to wait until they failed at least two trials, we could go immediately to esketamine, and obviously ECT and esketamine, if there's a way we could distinguish which population may respond better to one treatment modality over the other, that would be advantageous. And other therapies that may have this rapid antidepressant effects, including psychedelics like psilocybins, other molecules that modulate the glutamate GABA signaling, and maybe inflammation has a role in this. Other things to consider are there other roles, applications for esketamine besides treatment-resistant depression and major depressive disorder with suicidal ideation or behavior, and could we possibly treat bipolar depression? Currently, it's not approved, FDA approved for bipolar depression, but we know that depression is a big part of bipolar disorder, and a lot of people suffer from the depressive part of the bipolar disorder, and it would be nice if esketamine could also be effective in treating that depressed bipolar depression. And also, is there, there's something about esketamine. At least in our clinic, we've seen that esketamine sort of promotes this resiliency in patients, and that they're able to handle stressors is better. And I think that may be similar to why maybe the suicidal ideation may resolve quicker with esketamine, or is effective in treating those suicidal ideation, is that perhaps there's more tolerance to the stress and able to maybe cope with stressors in life better. So maybe that could be one of the things that we could look into in the future as well. Yeah, so this concludes my talk, and I'll be happy to answer any questions.
Okay, just as a reminder, one, thank you for everyone for coming out today. And if you do have any questions, please make sure you put them in the Q&A box or in the chat. So we'll just wait a minute for Dr. Kim to join. Hi, Dr. Kim.
Hi, Brian. How are you?
I'm doing well. How about yourself?
Good, thanks.
Excellent. So we have had a couple of questions that have come in. One is it's about the contraindications of esketamine and what should be considered once a patient's on it. What are some of the things to be concerned about?
Yeah. So the big contraindication is if there have been any bleeding in the past in the brain, so intracerebral hemorrhages, or any type of vascular malformation, such as aneurysms, and those all are related to related to the side effects, a common side effect of esketamine, which is increased blood pressure. So if you have these, if you have a medical history of these problems, then potentially it could lead to another rupture or another episode of bleeding and so forth. So that's a big contraindication, and for that reason, we check blood pressures 3 times during the esketamine treatment, once at the beginning. And if your blood pressure is severely elevated, then we will not proceed with the treatment. And then we check another blood pressure around 40 minutes into the treatment. And then finally at the end, before you leave the clinic, just to make sure that the blood pressure is coming down. The other contraindication really is, if you've had exposure to ketamine, maybe as an anesthetic or something, and you're hypersensitive to it or have allergic reaction to it, then that would be a contraindication for the esketamine treatment.
Fantastic. So the next question is the dissociative effect needed to see benefits from esketamine treatment?
Yeah. So that is a question that I get asked a lot in the clinic. And, I don't know if it's partly due to psilocybin, how with at least psilocybin, it seems like you need that experience for it to be effective as an antidepressant. But it in our experience, and I think it may be true for other clinics as well, that you don't need that dissociative effect, sort of this hallucinogenic effect or anything like that for it to be effective. We've had plenty of patients who never experienced dissociative symptoms. They just feel sedated and tired, and nausea is actually also common as well. One, maybe because of the taste, but sometimes they do get lightheaded and dizzy from the treatment. So yeah, so we don't see that being a key factor in seeing any antidepressive effects from esketamine.
It's great. There's a bunch of questions that are kind of flowing in now. So, so one is it required to have failed several trials of oral antidepressants before receiving ketamine treatment? And if not, then in which cases would ketamine be considered viable?
So it currently you need to fail at least 2 oral antidepressants. And one, I think, is that the insurance company will not approve for the drug unless you have 2 failed trials of oral antidepressant. I don't know if they consider failed ECT as, one big one, but a lot of people end up failing multiple trials before getting ECT anyway. So, but yeah, so that is at least in our requirement as well, which is that you have failed at least 2 oral antidepressants. But our clinic, as the data shows, that that is really not the problem for us, that because many of our patients come in with multiple failed oral antidepressants.
Great. Another question is there improved outcome when administering ketamine during a psychotherapy session and/or EMDR?
Yeah, I guess I don't know if there is a data out. So maybe that person is referring to any benefit of ketamine or esketamine assisted therapy. I don't know if there are, I guess, reliable data out there, but I think there have been, again, suggestions maybe it may be helpful, but we really don't do any type of therapy during treatment. One, because they're really out of it, at least during the first hour of the treatment. They're sort of really out of it and sedated. So, you couldn't really have a therapy at the time. So, but people seem to be improving without therapy.
Excellent. And then the last question really deals a little bit beyond ketamine and really about psychedelics overall. What is the future of psychedelics beyond ketamine? And can you just touch on that from a high level perspective?
I guess, Brian, like, I don't know if I guess, are you asking, are there other applications of the like psychedelics, or is that?
Yeah, so I think they're looking for other, what they're asking for is the future of psychedelics in general, and beyond just what we talked about today, which was esketamine.
Yeah, so the future of psychedelics, like psilocybin and MDMA, I think probably will get approved by FDA for treatment of depression. And, I think, we're in the very early stages of maybe discovering other potential for the potential application of these drugs for other psychiatric disorders. But again, a lot of research and clinical trials need to be done.
That's fantastic. So I have one more that just came in, and then we'll probably stop it here.
Sure.
It says, for patients, how do they go about finding a legitimate ketamine clinic? My understanding is that there's a lot of variability in ketamine clinics since it is not FDA approved for depression.
Right. So for IV ketamine, it isn't approved it is not approved for treatment-resistant depression or major depressive disorder with suicidal ideation and behavior. Yeah, I think there are a lot of clinics that open up for IV ketamine, and yeah, I don't know how you would maybe distinguish one's a reputable one versus not. But I think really the data suggests that IV and intranasal esketamine are equally effective. So I would maybe recommend, at least going with the one that was actually approved for those indications.
That's great. Well, again, I want to thank first Dr. Kim for doing this for us, and hopefully everyone found the information incredibly useful. And we will be sending, one of the questions that people have been asking is about the video. A video of this, including the Q&A, will be shared with all the attendees and anyone that registered for the webinar as well. So you should be looking for that in your email. I would say within, the next week, we will be sending that out. At the conclusion of this, we'll also be having a survey. So your feedback is incredibly important to us. So if you wouldn't mind, please fill that out, so we can bring more webinars from Unbound Medicine and Johns Hopkins Medicine to you. So in addition to thanking Dr. Kim, I want to thank everyone for attending today. I know your time is extremely valuable, and we're really thankful for you spending it with us. And if there's any questions at all about this webinar or about webinars in general from Unbound, please email us at webinars@unboundmedicine.com. If you had a question that was not answered, we will be happy to answer that question and email you a response as well. So once again, thanks a lot, Dr. Kim. I hope you have a wonderful afternoon, and hope everyone has a great day. Thank you very much.
All right. Take care.